Keynote lecture. Welcome to this instruction course, and he'll be talking about management of subluxated bag IOL complex.
Thanks, Dr. Narang. And I would like to thank Dr. Verma, the chairman of the scientific committee, for this invitation to speak at this meeting. In fact, Dr. Narang's covered most of fantastic points in her talk, and I think I'll be touching on some of those in my talk as well. So I was just going to quickly speak about causes, the pre-op evaluation and planning, and the surgical techniques that I use for management of a subluxed bag intraocular lens complex. It all depends on whether, what type of IOL is in the bag, is in the cavity, whether it's a 3-piece or it's a single piece. And so depending on that, I do either vitrectomy with externalization and scleral fixation of the haptics, or scleral fixation of an Alcon CZ70BD. And now in Perth, we are using a yellow, blue blocking yellow hydrophobic foldable lens with a 4-point fixation. So the most common causes for subluxed bag IOL complex are trauma, high myopia, multiple previous surgeries, and of course, most commonly pseudoexfoliation, uveitis, connective tissue disorders, and idiopathic as well. The key to any surgical success is a very careful pre-op evaluation and planning. We must always examine the patient, ascertain true phacodonesis, and examine the patient both in the sitting and supine posture, lying down. Because there was a patient who came to me. He could read 6/6, but whenever he lay down and looked at the ceiling fan, he couldn't see it. His vision was hand motions, because his lens was just the whole lens bag complex was suspended by just a couple of zonules superiorly. And like Dr. Narang touched in her topic, always use, if you have the luxury of UBM, use UBM to tell you, whether how much zonules are missing, or whether there was some, a previous iatrogenic fixation with Prolene that has given way with wear and tear after 10 years or so, and to see how much vitreous is there. So all this helps in the pre-op planning. And presence of vitreous in the AC and the location of the subluxed bag intraocular complex, whether it's in the anterior vitreous, mid-vitreous, or posterior vitreous, depends on, allows you to make a careful clinical decision about the plan. And you always have to look at the type of the IOL which is in the bag, which is subluxed. If it's 3-piece, you can just, vitrectomize all these Sommerings ring around and externalize the haptic. If it's just a single piece, then we might have to explant the whole complex. So the surgical technique that I use, depending on the patient, either a retrobulbar or a GA, and I always ascertain conjunctival scarring, because based on the technique of externalization of haptic or Gore-Tex fixation, you don't want the haptic or the suture knots being exposed. So I always ascertain conjunctival scarring and mark the 2 points 180 degrees apart. And you have to maintain AC stability with use of viscoelastics when you're explanting the complex, so that to preserve the endothelium and have a nice clear cornea. And like was suggested, we always must visualize what we're doing. You can either use an iris hook or a Mehl-Eugen ring, depending on what you're comfortable with. And I usually combine mine with vitrectomy, because being a vitreoretinal surgeon, I get the shivers when I see vitreous being pulled right, left, and center. So this is my first case where there has been this is a relatively fresh subluxation of the bag lens complex following severe zonular dialysis after cataract surgery. Within 2 days of the cataract surgery, you can see the lens floating about there. So what I do is I mark 180 degrees apart, and then take 1.5 millimeters from the limbus. What I'm using here is just a 1 millimeter standard side port knife to make 2 grooves, 180 degrees apart, up to about 2 millimeters. And now I'll do a standard 3-port vitrectomy, and now I'm taking a 25 gauge needle, and I make this entry just inside the lip of the groove. And now I clear up all residual vitreous, because the last thing you want is any traction, whilst you're externalizing the haptics. So once the vitrectomy is done, I use max grip forceps to externalize the haptic. And surprisingly, what I found is, max grip forceps are much better to use than the ILM peeling forceps, because the ILM peeling forceps would not go through a cannula made by a 25 gauge needle, but a max grip would go through it. So then I externalized the haptics, both of them, and then I use a Kelman-McPherson to tuck it into the groove. The tip here is you must always grab the edge of your tunnel, which allows easier implantation rather than blindly poking it. Okay, I'll move on to the next one. And here, in this case, there was a subluxed bag lens complex with a CTR as well. So I'll cut through to the chase. You know, I'm just making, because I know that I'm going to explant the whole one-piece IOL. I'm just going to make a 6 millimeter scleral tunnel, so that it's self-sealing and it's astigmatically neutral as well. And I think all of you are experts in this, so I don't need to show you this. And here, and then I mark 180 degrees apart. And I've marked my points as well. And now I put 4 trocars there, and now you can see the subluxed lens and the whole CTR complex as well. And what I find best to lift this is, you know, you can either use a micrograsp or a MaxiGrip forceps to grab the edge of the rexus, which is fibrosed, or you can use extrusion extrusion on the vitrectomy system with max vacuum to lift the whole complex. So here I'm just using MaxiGrip forceps to grab the edge of the fibrosed rexus, and I lift it up. So we don't have to use PFO or anything to float it up. And then what I do is I do a handshake technique so that I hold the CTR with one of the MaxiGrip forceps whilst I go in and extend the wound and make a corneal incision. Yeah, and so now I'm removing this. And here I'm using a Gore-Tex suture. Gore-Tex is polytetrafluoroethylene. It's a CV8 Gore-Tex suture, which is 7O, which is an amazing material, you know, very fantastically biocompatible and inert. And I'm just I'm using that through the CZ70 lens and putting a cow hitch suture knot. And you might ask me, why am I not just passing the suture through the eyelet in the Alcon CZ70? But when we did an audit of 25 or 30 cases, we found that they were tilt, you know, because the lens is rotating around the suture. So I'm doing a cow hitch suture knot around that eyelet and then externalizing it through each of these 4 trocar cannula systems. And so now I pull out all of them and I tighten it up. And this is, the Gore-Tex suture is used in cardiac surgery, so it's fantastically inert, doesn't cause any inflammation whatsoever. And all you see is just 2 white lines underneath the conjunctiva. So that is fantastic. So I won't show you this, and then I'll just go on to the next one, where, you know, this is, I'm using the MicroPure 123 lens by Physiol. You know, I'll straight cut to the chase now. I'll take that out, you know, and I'll show you the lens. This is a lens which is like the Acryos AO. It's a yellow lens with the 4, you know, loops. So we just go with the Gore-Tex under, over, and under, and then I grab them out. It's a very non-traumatic way of taking all these out with the MaxiGrip forceps, and then I pull out all these cannulas and tighten it up. The main tip here is to not get the sutures entangled or twisted. And then this lens can go in. The beauty of this lens is you can put it even in a foldable incision of just 2.6 millimeters, or you can fold it and roll it in. And then I remove the ports and I suture. Sorry. So in summary, externalization of scleral and of the haptics is excellent for sublux 3-piece IOL. If you're ever in doubt and if you want to use a suture to fixate the bag IOL complex, you can use Gore-Tex, which has fantastic biocompatibility and doesn't cause any inflammation. And MicroPure lens is a good alternative to have a hydrophobic yellow blue blocking lens. Thank you so much.